Thank you for joining us today. This is a third in a series on personality disorders that I have done. So we've already done presentation on narcissistic personality disorder and one on antisocial personality disorder. And this will be our final on borderline personality disorder. And we'll talk a little bit about how those are related. So if you're interested in the other two presentations, you can go to our website, hopeandhealingcenter.org, and I believe that they are archived there. So let's get started. As Cody said, I will present for a while, and then we'll have a time hopefully for questions at the end, if you could just type those into the chat. So today we are talking about borderline personality disorder, which is a very destructive and debilitating illness that really affects individuals in a way that is much more destructive than many of the mental illnesses that we have talked about on our presentations here. So I wanted to begin by, as I've begun in all of these presentations on personality disorders, with some discussion just of what a personality disorder is. A personality disorder is a long-lasting, rigid pattern of maladaptive thoughts, feelings, and behaviors. This is different per se than what you think of as a traditional mental disorder. Whereas with a mental disorder, say for instance, with something like depression, an individual may have a depressive episode at some point in their life, but prior to that depressive episode, they probably were doing very well, and then they come out of that depressive episode, and they may again have a period of time where they're doing well, and they may have another depressive episode at a different point in life. With a personality disorder, this is really something that is often described as it's part of who the person is, that the individual, as their personality has developed, as they've been growing, as they move into that late adolescence around 18, 19 years old, this really is how the individual, how they think, how they act, and how they feel is affected by the disorder, and really manifests itself as the person's kind of core personality. Now it's enduring. This isn't something that just kind of comes and goes. It's really very rigid and inflexible. And so we really need to think about it in that kind of a sense, because it does have kind of a very much a qualitative difference than the way we describe other mental health problems. So there are a number of personality disorders in the diagnostics manual. As you can see, they tend to be broken down into these three clusters, A, B, and C, and we are in the B cluster, which is also called dramatic erratic. And all of the personality disorders in the cluster B section are, they have common features of lack of impulse control, problems with emotional regulation. If you think about something like antisocial personality disorder, as we've talked about before, the individual is very impulsive, they can be very aggressive, they don't really have much concern about the consequences of their behavior. Something like narcissistic personality disorder, the individual's really unable to assess the emotions of others, they lack empathy, they can be very kind of manipulative. And borderline fits right into this same dramatic cluster. And so we'll see how there's some overlap with that. But you can see the other personality disorders, and they have they vary kind of in their core features. But we tended to be looking at this cluster B of personality disorders today. All right, so borderline personality is characterized by a persistent pattern of unstable self-image, emotional instability, self-destructive impulsive behaviors, and volatile interpersonal relationships. We're going to talk about all of that today, but that really is kind of a very simple one-sentence definition of what borderline personality disorder is all about. And we're going to talk in depth about each one of those as we go through, but I do want you to kind of remember as we go through, and I'll mention it several times, really the core or kind of the heart of borderline personality disorder is the person's kind of a sense of unworthiness, a sense of rejection. The person does not feel like they can be loved or connected to. And so they really, in a sense, are lashing out beyond them because they really do not feel they have any value or worth. And we'll see that as we go through and talk about the disorder itself. All right, so I think I really kind of wanted to start out by talking about why in the world is this thing called borderline personality disorder, because a lot of people really don't know the history of that, and the term itself. I mean, if you say someone's depressed, or you say somebody has antisocial personality disorder, those names kind of define or tell you what the illness is all about. But what does borderline even mean? Does that have anything to do with the way we think about it today? Well, there was a time in psychology and psychiatry where really basically all mental health problems, all mental illnesses were put into two categories. They were either a psychosis or they were a neurosis. And you can see how I have them kind of divided up there on the slide. And the psychoses were more severe. The personality of the person was fully distorted. They had delusion, hallucination, much like we think of psychosis today. On the neurosis side is much less severe. The reality testing was intact. They knew what was real, what wasn't real. They're not delusional. And only personality was only partially involved. And this would be like anxiety disorders and depression. But this is before those types of things really existed in that, described in that way. So you had psychoses and neuroses. So someone would come to a psychiatrist or a psychologist of the day, and they would say, well, you are struggling with a psychosis or you're struggling with a neurosis. Well, then it was realized that there was a set of individuals that seemed to be manifesting a problem that kind of seemed to be in between the two of these, that it was, as Adolf Stern said in 1938, who's the gentleman who came up with the term borderline, that they were on the borderline between psychosis and neurosis. In fact, he even believed that it was a mild form of what ultimately we would describe as schizophrenia today. So borderline personality disorder, this is before it was called a personality disorder, was just referred to as borderline because it was on the borderline between psychosis and neurosis. And that's in 1938 where we first began to hear that term used. Well, then a person by the name of Otto Kernberg, who's really a seminal researcher in personality theory and focused more on personality than what you would think of as, say, things like depression or things like that. He kind of adopted that concept, looking at the idea that within mental illnesses, the personality was what was driving them. And so he then put this onto a personality continuum, and he talked about a psychotic personality and a borderline personality and a neurotic personality, very much moving on from Adolf Stern. He's really just taking that and putting it into a personality context. And so really, if you think about it to some extent, these are those three clusters that we have now. We have the cluster A, which would be more like your psychotic. We have cluster B, which would be the borderline-like personality disorders. And then you have the neurotic, which would be the cluster C. And so we see that today. And so Kernberg was the one who gave us, and this is the 1960s, this gave us this idea. And then in 1980, this is the Diagnostics and Statistical Manual of Mental Disorders. This is how we diagnose individuals with a mental disorder. And you can see all of the editions here. This is our most recent edition, DSM-5, but you can see this is the original edition here, DSM-1, 2, 3, then a revision of 3, 4, then a text revision of 4, and then 5. But it was in DSM-3, the green one there, in 1980 is when that was published. And that is the very first appearance of the term and the diagnosis of borderline personality disorder. And so I say all that really for two things. One, I want you to understand that the concept of a borderline, the name itself, is highly antiquated. It really has no meaning anymore. And it has been suggested that we should change this to something like emotionally unstable personality. There's been a lot of different suggestions, but also to let you know that the actual diagnosis of a borderline personality disorder really hasn't existed since 1980. So it's a relatively new diagnosis. This isn't something that has existed in antiquity, but certainly individuals that showed these types of behaviors and these problems were, even as you can see there with Adolf Stern, he was recognizing that in the 30s. And so just gives you an idea of why it's called borderline. All right, so what is the epidemiology of this? It's about 1 to 2% of the general population. So in mental health terms, it's relatively rare. Late teens to early adulthood. I mean, technically, an individual cannot be diagnosed with personality disorder until they turn 18 years old. But you certainly can begin to see some of the telltale symptoms or signs of the disorder in late teens. It's predominantly diagnosed in women, although in a 3-to-1 ratio, although there has been some argument that that is just more of a gender bias, that women that show behaviors in this, within the realm of borderline personality disorder will be diagnosed with borderline personality, whereas when men show a very similar profile, they will be diagnosed with antisocial personality disorder, because there's a significant overlap in those two disorders. Because antisocial personality disorder is really almost exclusively diagnosed in men. The ratio is much higher, men to women. So there's some suggestion that there may be a greater equivalence in diagnosis in men and women, but with that, there's just a gender bias in diagnosis. The heritability is quite significant, greater than 50%. The variation can be accounted for by genetics. So there is a heritable aspect of this. You do see that it can run in families. There are a significant number of co-occurring disorders. So you will typically find that people who have borderline personality disorder also will meet criteria for other disorders, particularly substance use disorders, very high rate of substance use in individuals with borderline, but also depression and post-traumatic stress disorders. Those are very, very common in individuals with this diagnosis, as are anxiety disorders, eating disorders, and then overlap with other personality disorders. It's also not uncommon to have someone who, say, has borderline, but also may meet criteria for antisocial or narcissistic. But there's a significant overlap in the criteria and the symptoms of those illnesses, so that's not surprising. In some sense, it may be just better to say the person has a cluster B personality disorder with borderline features or with antisocial features or so forth. 10% of borderline disordered patients will die by suicides, extremely high rate for mental illness. And 60 to 70% will make an attempt. So there is a significant risk of individuals with borderline personality disorder harming themselves, both through suicidal behavior, but also through self-harm, which is very common also. And it has been demonstrated that as high as 70% of individuals with a borderline personality disorder diagnosis have some type of early childhood trauma. And so that's extremely common as kind of a contributing factor to this disorder. So if we do look at the risk factors that are associated, again, none of these are, if you have this, then you're going to have borderline. These are just highly correlated with the later appearance of borderline personality disorder. Childhood maltreatment, as I mentioned, is extremely common in these individuals. So you could have, like I said, the recent study showed 71% of individuals with borderline personality disorder had early childhood trauma. Maternal separation, poor maternal attachment, parental substance use, serious parental psychopathology, or invalidating family environment. All of these put an individual at higher risk of a later diagnosis of borderline personality disorder. And again, if you'll remember, as I said when we began, really what we're looking at here, the kind of the core of this disorder is this kind of sense that you have no value, no worth, that you are unlovable, and that others are simply going to let you down and reject you or abandon you. There's a tremendous sense of fear of abandonment in this. And if you makes sense if you look at this, if you've gone through childhood maltreatment, if you have maternal separation, you don't have good attachment with the mother figure, the substance use or psychopathology in a family where the parents are then distanced or invalidating family environment. In a sense, the child has the genetics of these individuals that are raising them, that are doing these things, but also they're being taught in a sense that you are not worthy of a solid relationship. All right, so let's look at the diagnostic criteria for the illness. Unfortunately, with a lot of the illnesses, we live in a time where I think the general public knows just enough about mental health problems to be dangerous. So you hear a lot of people say, "Oh, well, she's got borderline. That's very borderline." or even things like, with bipolar or depression, or we use these terms very cheaply. And I think it's important to understand that there is a specified set of criteria that you have to meet. And those criteria are fairly rigid and fairly high. The threshold is high for the diagnosis. So, you can have one or two of these and not have a diagnosis. So a pervasive pattern of instability of interpersonal relationships, self-image and affect, marked by impulsivity beginning in early adulthood. And then you have to have at least 5 of the following. Okay, so frantic efforts to avoid real or imagined abandonment. That is a classic aspect of the disorder. In fact, I have never encountered someone with borderline personality disorder that did not have that specific symptom. They are absolutely terrified that they will be abandoned by those around them, those that are supposed to love them and care for them, those that they are in relationships with. And oftentimes what occurs within this is what we see, number 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and de-evaluation. So you get this sense of, I love you, I love you. There's this over connection, this very intense relationship, which can be very affirming to both individuals. But then because of this tremendous fear of abandonment, the person often sabotages their own relationships unconsciously, and then goes from loving the individual to absolutely despising the individual. They're the worst person that ever happened. In fact, one of the most famous books ever written on borderline personality disorder is actually titled, "I Hate You, Please Don't Leave Me." And so it's kind of a classic book, but it's also a kind of a classic statement in the context of borderline, that one minute, literally one day, the person can be absolutely madly in love with the individual. This is the best thing that's ever happened to me. This is the best person I've ever been with. And the next day, because of a stressor that occurred, this person is destroying my life. I hate you. Don't be around me anymore. I never want to see you again, with very little understanding of why. Identity disturbance, the person really often doesn't understand or know who they are. They have no sense of self. They are unable to make plans for the future because they really don't know what they like or don't like, what they want to be or not be. Impulsivity, at least 2 areas that are self-damaging. The self-damaging impulsivity is one of the most disturbing and dangerous of the symptoms. These individuals really engage in behaviors that are self-harming. And sometimes in a very specific sense where they actually do harm themselves, but they overspend, they're involved in, sometimes they can be involved in risky, promiscuous sex, substance use is common, binge eating is common. And so as I have the next suicidal gestures we've mentioned, but also self-mutilating behavior, cutting, burning, hurting yourself. So again, the individual in a very unconscious sense despises themselves, hates themselves, and believes that others, that they have no value and worth. And so you see that in the relationships. They desperately want to be in relationships, so they'll try to form a relationship. They'll kind of over-relate to the individual. And then when any little thing goes wrong or any little thing seems out of order, they destroy the relationship. And then they begin to harm themselves through these kind of self-damaging impulsive behaviors or self-mutilation or suicide attempts, because again, they do not believe that they are valued or have worth. Affective instability, they have very intense moods, and we're going to talk about that in a few minutes. A lot of irritability, a lot of anxiety, chronic feelings of emptiness, which often will come across as depression. Very intense anger and difficulty controlling that anger. They have what I would refer to as impulsive aggression. They will lash out and with very little provocation. That can be physical, that can be verbal. Again, we'll talk about this kind of reactivity in a moment from a neurobiological perspective. And then also kind of in a more severe examples of borderline, you can actually get paranoid ideations and some dissociative symptoms, really with the paranoid ideations, almost to the point where a person seems like they're delusional. And with the dissociative symptoms, where a person really doesn't seem to know where they are, what they're doing. It's almost as if they're different people. And so there can be some really almost like psychotic disordered features. So again, you can think back to Adolf Stern and his idea that this was almost a mild form of schizophrenia or psychosis at the time. He was seeing obviously a more severe kind of manifestation of this, but that's why he stuck it at the borderline, because it looks like a neurosis on one side, it looks like a psychosis on the other. So in his idea, that was a borderline disorder. So this is how we get the diagnosis of the disorder. And I found this little, actually there's a whole set of these for every mental health problem that's in the DSM, but I like this because it has some reminders on here to kind of help us remember some different things. So the unstable moods are very common. And again, it's not that the moods just vary, it's that they vary to the absolute extremes, from intense joy to absolute rage. And up here in the corner, the classic stable instability, the only thing that's predictable for the borderline patient is that they will be unstable. And so this very intense joy to rage. There's a defense mechanism that individuals with borderline personality disorder use called splitting. Splitting is the idea that everything is either good or bad. There is no in between. It's black or white. There is no gray. So you are either a wonderful person or you are a horrible person. This is a great job. It's the best job I've ever had, or it's the worst job any human being could ever have. I could never possibly work there. So it's always the extremes. As I mentioned before, the terrified of abandonment, and then the relationships. They can be intense. They're intense, and they can be wonderful relationships at the inception of the relationship. But at some point, they will go sour, and they will turn into really destructive relationship. And that really is where the family has the most problem with people with borderline personality disorder, is that they're really unable to maintain a really kind of a healthy kind of positive relationship, because they will vacillate between, everything's wonderful to everything is absolutely horrible. People with borderline personality disorder often alienate themselves from their family just because of their feelings and their thoughts towards their family. There has been a great deal of work done in the neurobiology of borderline personality disorder. In fact, there has been much discussion over the years since 1980, when borderline was put into the DSM as a personality disorder, that perhaps it should not even be listed as a personality disorder. Perhaps it should be listed more as its own separate mental illness and not viewed as a personality disorder, which again, there's a qualitative difference, but still a mental health problem, and a serious one at that. So these are the areas of the brain that have been demonstrated to function abnormally in individuals with borderline personality disorder. You have this in the blue here, the light blue, the dorsolateral prefrontal cortex, the anterior cingulate gyrus, anterior cingulate cortex, the insula, the orbital frontal cortex, the amygdala, and the hippocampus. And really, in a sense, what you have here is you have a whole set of prefrontal cortex. You have areas that are involved in emotional processing, and then emotional memory. So really what you have is a loop that's involved both in emotional regulation and an emotional expression. And also behavioral control when you look up here into the prefrontal cortex. And since it is dysfunctional, what you have is, in a sense, what we see manifest in borderline personality disorder, which is emotional instability, just an inability to maintain healthy emotions, a lot of impulsivity, an inability to control your behavior, and then with the amygdala, a lot of intense anger and fear that goes along. So if we look at some studies that have been done, this is one that I like, where we're looking at this. We're looking at this region right here, which is the anterior cingulate and the prefrontal cortex, and then over here we're looking at the amygdala. So let me just kind of give you some description of that first, and then I'll explain what this is. You need to think about the prefrontal cortex, this blue area here, and down even into this yellow here. That's kind of the brakes of your brain. That's the brake. So if you compare that to a car, the amygdala here, it breaks in the context of emotion. The amygdala here, that's the engine, that's the driver. Okay, so it's driving it's analyzing the environment continually, saying, is there a threat? Is there some reason I need to be angry? Is there some reason I need to be fearful? It's always looking for a threat, always looking for a concern in the environment. Okay, so normally what will happen is it will assess what's going on, and maybe let's say that your coworker said something to you that might be taken as a mild insult. Okay, so your amygdala says, hey, that's a threat, I don't like that. Okay, and why don't we react? Okay, well, your prefrontal cortex says, okay, hang on, I'm at work, that guy, I'm not exactly sure why he said that or what that, but if I just react, especially if I react angrily or aggressively, I may lose my job, I might get arrested, I might, who knows, there's some negative consequences. So I'm going to slow down and I'm going to analyze the situation, and I'm going to make an informed decision about what I'm going to do, because there are consequences to my behavior. All right, so now, what do we see in the patient with borderline personality disorder? Well, in this study, what they've done is they've had the person perform a task while they're in an fMRI, where they have to either inhibit their behavior or not inhibit their, so they either react or not react. And what you find is that if you look over here, and the blue is the comparison subjects, and the orange is the borderline subjects, you can see that what you should see is an activation of the prefrontal cortex, and then you should see a diminishing of activity in the amygdala, because the prefrontal cortex is saying, okay, inhibit your behavior, stop your behavior, do not react. Whereas the amygdala tends to say, go. And so you're seeing that in the control subjects. But then look what happens in the people with borderline personality disorder. Their prefrontal cortex is underactivated. Okay, it actually isn't saying stop, and you have this overactivation in the amygdala. And so that is what it is to be to have borderline personality disorder. When you look at a situation, regardless of what the situation is, regardless of whether a person without borderline would look at it as a threat, you see it as a threat. And you do not have the brakes to keep yourself from reacting. So when you are saying to yourself internally, I have no value, people are going to reject me, I shouldn't form relationships, I'm in this relationship and I know that my husband is going to leave me, I know that he's cheating on me. Well, anything that you see in the environment, you see as a threat. And so it's a self-fulfilling prophecy. I know he's going to leave me, so unconsciously I sabotage the relationship. So what does that look like kind of in a behavioral way? So we're looking at arousal here, kind of emotional reactivity, how physiologically and emotionally aroused you become. So here's a stressor that occurs regardless of what level stressor, any level stressor. So you can see for the healthy individual, there's some increase in emotional arousal, and then it kind of diminishes because your amygdala gets activated and your prefrontal cortex says, okay, let's take a minute here. All right, it's going to all work out. Okay. But in the borderline patient, you have a completely different response. Any little trigger that they perceive as a trigger will cause a heightened state of emotional arousal and physiological arousal, which, because they're so aroused, it affects their cognitive processing. They begin to show suicidal behavior and self-harm and anger and impulsivity. And you can see how long it takes for them to come back down. So this is that emotional reactivity that occurs where the individual becomes hyper-reactive emotionally. And this could go on for hours, it could go on for days sometimes before the individual comes. And so what happens is, you know, the boyfriend comes home and he doesn't say something that she thought he should say. So she reacts. And by the time this episode is over, she has destroyed all of his clothing. She's left the house. She's gone on a bender and she's used substances or alcohol, and she's contemplating suicide. And then we come back down to normal, and the person isn't fully aware of exactly what happened. Why did this occur like this? And this is a constant cycle that happens time and time and time and time again. And that's why in individuals with borderline personality disorder, you often find that they've driven away their families, because people become very, very kind of tired of this kind of behavior because they feel like the person should have control over it, when in reality, they do not. This is not something that they can just think their way out of. They do need treatment. And thankfully, there is treatment today for individuals with borderline, and there is support for families. So how do we treat borderline? I will tell you that if you remember in 1980, that was the first appearance of borderline personality disorder in the DSM. It was not the first appearance of a personality disorder, but it was the first of borderline. When I went to graduate school, which was in the early 90s, okay? Well, actually, I should say in the late 80s into the early 90s, so that late 80s, early 90s, we were actually taught that there were no treatments for borderline, for any personality disorder. The only treatment was intensive long-term psychotherapy, and that was, or psychoanalytic type of psychotherapy, and that was likely not to be effective. And so luckily today, we do have some therapies that have been developed, and most of them developed specifically for borderline personality disorder that are very effective at treating borderline personality disorder. Now, that being said, it is not that the therapies do not work. It's just very, very difficult to get an individual with borderline personality disorder to recognize that they have a problem and then to stick with the treatment. Because remember, they have a real they lack a sense of self-awareness. And so it's not that they don't understand or recognize that the things around them are not going well. It's that they externalize where the problem is. And so the problem is that everyone rejects me. No one loves me. No one cares for me. That's the problem. And so I don't have any value. It's not that there's anything wrong with me that's driving people away or that I'm sabotaging relationships. It's that I'm only reacting to what's coming at me. So it's very difficult sometimes to convince a person that they may actually need to get treatment. And really giving someone the diagnosis of borderline personality disorder is often not very helpful because the first thing people do when they get a diagnosis of any type is they get online and they Google it. And if you get online after this presentation and you were to Google borderline personality disorder, you're not going to see a lot of positive stuff. And so people are going to be, well, I don't have that. I don't want to be like that. I don't want people to think of me that way. So it's very difficult to get these individuals into treatment. Not impossible. And the treatments can be highly effective. So from the psychotherapy perspective, a talking therapy, the dialectical behavior therapy, DBT, is a very common approach that's used with borderline clients today. In fact, here at the Hope and Healing Center, we have a DBT program. And I would say most of the time, the majority of people in that program do have borderline personality disorder, although it is good just for emotional instability in general and suicidal behavior. And then mentalization-based treatments, which is MBT, have also been developed for borderline, and they can be very effective as well. So those are two talking therapeutic approaches. Now, it often has been discussed, and you can even find it online. It'll say that, there is no pharmacological treatment. There is no drug treatment for borderline. And that's true in a kind of a very narrow sense. I can give you might have depression, and we can give you an antidepressant, and it specifically treats your depression, the underlying causes of your depression. We do not have medication that specifically treats the underlying causes of borderline personality disorder because those are not all that well understood. But we do have medications that can treat the symptoms and problems associated with borderline and the coexisting conditions. So a person with borderline personality disorder that was receiving, say, dialectical behavior therapy may also be helped by taking a mood stabilizer like Depakote or Tegretol or something along those lines, Topamax, as well, or atypical antipsychotic to kind of tighten up their thinking, to give them more control over their behavior or their moods. So you can treat some of the symptoms. You're not necessarily treating borderline, but you're minimizing some of the symptoms. And same thing with the coexisting conditions. If you have an individual who's has borderline personality disorder and they're very they're also struggling with depression, an SSRI, an antidepressant might be very helpful. Same thing if they have PTSD. Because remember, a vast majority of these individuals have suffered trauma, which is kind of one of the core features of borderline. And they indeed may be struggling with PTSD. And we do have some pharmacological interventions for PTSD or anxiety issues. So a combination of talking therapy and medication can be effective. So just to kind of give you some ideas of if you have someone in your life who's struggling with borderline personality disorder, it's much more difficult to transition the person into talking therapy than say it may be to help them with getting some pharmacotherapy. So my recommendation for a resistant client would be to say, okay, well, if I have a person with borderline personality disorder, but they also have depression. Most individuals would be open to getting treatment for depression. So begin with antidepressant for depression. See if you can get some improvement there. If you get some improvement there, then begin to either look for pharmacological interventions for other symptoms, or begin to move them towards treatment. Even if they were to begin or psychotherapy treatment, even if they went to psychotherapy for depression, the therapist could begin to work in some of these other techniques that might be helpful for their borderline features. So it doesn't have to be an all or none type of event. You don't have to say, well, you have to go get treatment for borderline or there's nothing. You might say, hey, I know you're really struggling with depression. Let's see if we can get you some help for that. And then begin to slowly kind of move them in that direction. Because any type of intervention that focuses on either symptoms or the overall disorder is going to show some improvement for the individual. All right, well, let's talk a little bit about families and then maybe we can open it up for questions. So families struggle tremendously. As with all mental health problems, the mental disorder does not only affect the individual who has the problem, but also their family and their loved ones and those around them, but particularly with borderline personality disorder, because it is, relationships are such a core component, kind of unstable relationships, a core component of the disorder. So really, if you're a family member and you have someone in your life who's struggling with this, you really need to educate yourself about the disorder. So you really need to be able to separate the person's behaviors and thoughts and from the bent thoughts, behaviors, feelings that exist because of the disorder. Okay, and then so the more you educate yourself, the better. The more you educate yourself about treatment, the better that you can point them to care and the way that you can help them. You need to also help your loved one develop some coping opportunities, so distracting activities or healthy coping strategies for times of distress. Times of distress for the borderline client will happen almost on a daily basis. And it's not things that necessarily distress you or I. They have a lower level of distress tolerance. So they're distressed by more. So they need to have an appropriate way to deal with distress as opposed to just kind of exploding as is very common in the disorder. So if you can help them learn appropriate coping, breathing techniques, meditation, whatever that might be, muscle relaxation, distracting activities like listening to music or going for a drive or a walk or exercise, whatever they might be, as long as they're healthy, you may help the individual not have as many reactive moments. And so, again, that's something that you can work on with them that can be very helpful for both you and them. Setting clear and healthy boundaries. Just because a person has a mental health problem or a personality disorder does not mean that they should be allowed to kind of run roughshod over the family. The family has to walk on eggshells to try to keep them from exploding. There have to be clear and healthy boundaries, what's acceptable in the home, what's not acceptable, what the consequences are, because healthy boundaries help people be successful. They give people a touch point of how far they can go and then what those consequences are. Sometimes people don't, in the time of the behavior, they don't think about the consequences. That helps them begin to learn the consequences. But again, you have to set those boundaries up so that the individual can be successful, and you have to understand what borderline is all about. So that's back to educating yourself. You don't want to enable bad behavior. If you have somebody, for instance, that has a borderline personality disorder in your life, and they also have a substance use issue that goes along with that, that's their impulsive, unhealthy behavior. you know, and they constantly asking you for money, and you know that when you give them money, they go and buy drugs for that, then, you know, you're just enabling their bad behavior if you continue to give them money. So you need to make sure that the way that you're supporting them, the way you're caring for them, the way you're assisting them is not enabling bad behavior, but making it easier for them to be healthy. You just need to try not to take what occurs personally. I'm not saying that you just ignore it. As I just said before, there has to be clear and healthy boundaries, and clear and healthy boundaries have clear and healthy consequences to what it is that these people may do. So, but you simply can't take it personally. If you know that your loved one has borderline personality disorder, then you have to expect that there's going to be emotional volatility. There's going to be instability in the relationship. There are going to be times where they explode. You have to understand that that is not your fault. And that is the result of the disorder. That is not the individual themselves. And so if you take it personally every time those things occur, and I'm not going to go back and connect with her again until she comes and apologizes to me, well, then again, you're putting the impetus on the disordered individual and not recognizing that it's because of the disorder that their behavior, their thoughts, their feelings are affected. And then finally, there's no reason to go through this alone. There are plenty of support groups. Here at the Hope and Healing Center, we have a support group called Families Transformed, which is specifically for the individuals, loved ones, or caregivers of individuals with a mental health problem. It would be a wonderful support group for you, but there's plenty of support groups out there for people who are caring for a mentally ill loved one, or who and there's lots of borderline support groups as well. So get into a support group, get a group of individuals that can support you, that you can talk to, that you can vent your frustrations, that you might ask for advice, because that's going to only help you. The more you cannot, cause someone else to act in a certain way against their will, but you certainly can control the way you act and the way you react. And that's going to affect the individual as well. So if you take care of yourself, then you're going to be able to better take care of them. And that's some of the best advice I think I can give you, is to take care of yourself. And that will allow you to be the person that can point them to the care that they may need. All right. Well, if you want to learn more information about, if you want to learn more about these kind of things, you can certainly go to our Mental Health Gateway website, which is mentalhealthgateway.org. mentalhealthgateway.org. We have a variety of trainings there and lots of resources on mental health problems. Or you can go to our main website for the center itself, hopeandhealingcenter.org, and you can contact us via that. So I will be happy to take some questions now about borderline, but I think, in closing, I would just say this: there are absolute effective treatments for this disorder. And your loved one may not be able to complete treatment the first time, because sometimes it's very difficult to get through treatment, but just keep trying, because there absolutely are effective treatments now. And your loved one is ill as opposed to bad. That's the way to think about it. These behaviors come as a result of an illness, not because the individual is a bad person. So hang in there, have hope, and please get support for yourself.